Well, thanks for coming. I'm Kent Smethers, the Bettner Chair Professor here at the Wharton School and Faculty Director of the Penn Wharton Budget Model. We're going to talk about Medicare for All today, and other speakers today will be Mark Pauly, who's the Benheim Professor in the Health Department here at Wharton, and was recently elected as the President of the American Society of Health Economists. He holds many other titles, and you can look at our event page, and it describes his bio in more detail. And Felix Reichling, who is a senior economist at the Penn Wharton Budget Model, is previously the chief of the Fiscal Policy Analyst Unit at the CBO. And many years before that, he was also the NCAA fencing champion. So if you're into fencing, he's your man. All right. So Medicare for All, I'm going to talk about kind of the model setup that we have. We've been working on it for a period of time, even before it was called Medicare for All. This is when we started working on this framework. And I'll set up and motivate kind of our framework, and then Felix will talk about some of the results, and then Mark Pauly will also talk about Medicare for All. Whatever Mark wants to say, it's always interesting. Whatever Mark wants to say is what he'll talk about, whether it's our analysis or motivating Medicare for all. So we project with our model that under current law, if nothing is done, those who are uninsured the rate of uninsured population will almost triple over the next 40 years. And I'll explain a little bit why that is. And so we examine, it used to be called a single payer system, now called Medicare for All, a system where we could transform, and essentially where workers now participate in Medicare. We're going to be focused on this case, not on the particular candidate's plan for Medicare for All. We'll be releasing Sanders' plan in a week or two. But in particular, we're going to be looking at a more stylized plan, a pure Medicare for All, where we simply open up Medicare and for the working age population as it is today. And so what we find is that if we were to shift to this type of system, a single-payer Medicare for All stylized system, it would actually increase life expectancy by about 2 years because of positive health gains. It would actually grow the population by 3% within 40 years, and it actually increase productivity due to improvements in health by about 5% over time. However, and this is the big takeaway for today, the actual funding mechanism, how you fund the program, is huge. And in particular, what we call premium financing, where you actually pay a premium that's independent of your income, and it will be subsidized by Medicaid if you can't afford the premium. This could actually lead, this entire system under premium finance, we'll define in a little bit, could actually grow the economy by 16%. Relative to most fiscal policies, that's a pretty big gain within 40 years. If you use a payroll tax that's now scaled to how much you make, this will in fact, now the results change. It will actually shrink the economy a little bit. And if you actually just try to deficit finance your way, you don't actually pay for it, you just throw on more debt, it will actually shrink the economy by 15% over 40 years, despite these other productivity gains. And so, in particular, what we did is we built lots of fancy terminology for economists here, hyphenated words, a heterogeneous agent, overlapping generations, general equilibrium, mini-period life cycle model. I actually wrote that, not Felix. That's my problem. In particular, this is the first rule framework that includes a lot of interactions that actually are really important. There's been other analysis that's usually been static, one-off type focuses. This incorporates a lot of interactions, including very rich demographics around the health, longevity, productivity dimensions, of course, income and wealth. Insurance markets, importantly, we don't just take those as given. We calculate the prices that would be changed in insurance markets, premium prices, as a result of changes in policy. This will actually, if pricing is not individualized, for those of you who have background in this, you know this could lead to adverse selection moral hazard that we capture. It's also inside the macro economy, so we get the macro feedback effects. And it also includes things like other government programs that exist. It turns out the interactions, sorry, I'm going to take more. The other interactions are, in fact, really important, as I'll explain. So households are differentiated by family compositions, incomes, wealth, and health. They face lots of sources of uncertainty, which include their wages, health state, even the medical costs within the health state, their mortality, and they make choices. The normal choices in most models is just over consumption, maybe how much to work, we have that, but also whether or not they want to buy insurance in the current system, out-of-pocket medical expenses, and there's interactions between health and productivity. Healthier workers are going to be more productive. Firms they offer group tax deductible group health plans. They face competitive markets, so that means if you actually replace Medicare for all, in fact, you get rid of the worker-based plans, then that means wages will in fact go up because firms care about total compensation. But they also face realistic constraints, such as they can't pay below minimum wage. So if a worker's value is actually below minimum wage, they're not going to get a health benefit. As a result of that, they could maybe go on to Medicaid, they maybe buy insurance on the exchange, and they will often drive down their assets and income to actually qualify for Medicaid that's captured by the model. So markets are equilibrium, fancy terminology for economists, that basically says we're computing everything internally consistent. Prices are not just given. Everything's internally consistent with all the other dynamics going on. We'll look at a 40-period transition path. And the government, not only do we capture Medicare, but we capture Medicaid in all its glory and detail, because there's lots of interactions there. Even with Social Security, as I'll explain, there's a lot of interactions that happen. When you change Medicare, you're actually going to change Social Security financing as well. And then we had to do some original data work, because a lot of the data work, for example, on wage processes, did not distinguish between how healthy people are. And it actually turns out one reason why wages go up is because changes in health status. And one reason why wages go down is changes in health status. So we had to re-estimate those things. And calculating all this in this large model, what we call a fixed point, is a beast to calculate, but nonetheless, it was something that Felix was finally able to get done. Let me just talk about some complex interactions what the model takes into account. And so suppose that you eliminate employer-based health care. So you get rid of the tax-deductible employer-based health care. In fact, we're going to look at runs where you actually move to a mandatory Medicare for all. It's not going to be just an opt-in thing. It's going to be mandatory. And so what happens, because the employer faces competitive labor markets, that benefit's gone. They have to increase their wages from a labor economics perspective in order to compete and attract that labor. So reported wages will go up, but workers are not better or worse off per se, except for the tax deductibility that they lost, because their total comp hasn't changed. That's the whole point of why wages go up. And what happens now, though, because the reported wages go up, actually their Social Security taxes now go up, because now Social Security is levied on those wages. And the income tax base has also gone up as well because of this change. In particular, you can't do Medicare for all without expanding the tax base, by removing the employer deductibility of that. Well, what do you do with that new revenue? Holding everything else fixed, that means you, in fact, have more capacity to pay down debt. That actually grows the economy by growing investments. And now we actually do have a real compensation change through these macro effects. Real wages now actually, even net benefits now actually would go up as a result of this. Premium financing, I'll explain the difference between that and payroll in just a second, but that actually has some interaction effects that are interesting. And also on the micro level, we also have some neat interactions. If your health suddenly declines, you may actually lose your work and have low income, but you may not have low enough income or low enough assets to qualify for Medicaid. But because now you're low income or low assets, you don't get health care. And that reinforces the fact that you actually have low health. So you can get these like income, health, poverty traps in the model. But then you have another population they actually select out under current law because they actually are really healthy. And it's just not even worth it for them. So you actually get these heterogeneous populations in the model, which you actually kind of see in the data. One pot is kind of healthy. The other one, and adding them covering them is actually cheap because they opted out first place because they were healthy. And then you have this other population that is actually sicker than average, and covering them is more expensive because they're in the kind of health poverty trap. There are certain things that we don't take into account here, state differences, things like that. We don't distinguish by race in the model. These things are not going to, they're all going to be the same across all the different financing provisions that we talk about, so they're not going to be that important. But I will say one simplification that we are using when we talk about real plans that we'll analyze and release in a couple of weeks is that we don't have supply rigidities right now. In particular, waiting lines, things like that, we actually are going to assume that there's enough capacity in order to absorb more people. So as I mentioned earlier, we we project with this really rich model that the uninsured rate is going to increase quite a bit, from 10 to over 27% over the next 40 years. So that's quite a bit. Those who are not getting any medical treatment, even you could be uninsured and pay out of pocket, and therefore you actually get medical treatment. And that's actually what the healthy people do. They often will forego insurance, and occasionally they break their arm, they pay out of pocket for that. And that rate will also triple as well. So what we're looking at is a pure kind of Medicare for all system. We're not expanding benefits at all. We're simply saying current working population gets the Medicare benefits as they are. We're not adding dental, we're not adding long-term care, we're not adding a lot of stuff that, for example, the Sanders plan does. We also assume that, in fact, there are big cost savings in Medicare, much lower overhead costs, but with reimbursement rates to physicians. The Sanders plan, for example, says they want to jack it down immediately. We do a more phased reduction over time. And so there's certain common things that I mentioned, but let me just also, we get the administrative costs. We get that from a previous study of CBO. They between private excess cost growth rates and Medicaid and so forth. But let me just hone in on one thing, and I'll hand it over to Felix to talk about the results. And that is this difference between premium finance and the payroll tax finance. It's not so surprising that if you just try to deficit finance a program this big, that it's going to shrink the economy through, in fact, more debt means more crowd out, more household saving, international capital flows goes to pay for consumption today through that higher debt, and less gets invested in. But the distinction between payroll and premium is an important distinction. And in particular, in both cases, it looks like I'm just paying it out of my paycheck, for example, that gets collected in the same way Social Security gets collected out of my paycheck. A premium could be deducted from my paycheck, or a payroll tax could be deducted from my payroll tax. Why do we get such big different macro results? And it really comes down to the following distinction. When something's premium financed, there's a really tight connection between the amount I pay and the benefit I receive. If I quit my job and I'm not paying the premium anymore, I'm not getting the benefit. And so there is that very tight connection between what I pay and what I get. In fact, the premium financing is actually not distorting to economic activity, except for really low-income people who are subsidized by Medicaid to pay their premiums, in which case they might distort their saving to qualify for Medicaid, or labor income to qualify for Medicaid, but it's not that distorting. Payroll tax, on the other hand, it sounds like it's very similar, but this is now scaled to your income. So on one hand, it's more progressive, but also means if I quit my job, I'm maybe the secondary earner. We don't really need my income in particular, because now we get health benefits. I quit my job, I still get benefits. So now you have a disconnect between what I pay and the benefits I get. Now that tax is fully distorting. There's no connection between what I pay and the benefits I get. and that will have a different impact in terms of my choices than a premium where that connection is much more direct. So premium is much more similar to sometimes called, what you see in some other countries, including a multi-payer type plans, things like that try to get the benefits of single payer, but it's what's payroll is how Medicare, to some extent, is currently financed. And there's other constructions and so forth, but we don't have the time to go into a lot of detail. Felix, why don't you discuss our main findings here?
Okay. All right. I'll be speaking somewhat slower than Kent. All right. So what this table shows you is how expanding access to healthcare affects health and productivity of the population in 2060. So as Ken mentioned before, the first line is under current law, the uninsurance rate will greatly increase to 27%. A lot more people will not receive care, and people will overall be sicker as a result. And the reason why this is happening is because healthcare, the cost of healthcare grows at a faster rate than the economy overall. That means over time, you just spend a lot more of your income on healthcare, and many people stop being able to afford that. So they don't get insurance, they don't get treatment. Under our policy, the three different policies we are analyzing, by construction, nobody's uninsured anymore because we require them to be insured. Less than 1% is not getting treated. Most of these people have really high medical expenditures that they don't pay. And then overall, people are a lot healthier. So there's a difference between 14.5% being in the sickest states and 13%. And with that comes an increase in productivity because healthier people are more productive. And so on average, they are roughly 5% more productive here. So this table shows you how expanding healthcare affects longevity and the population size. Longevity goes up by about 2 years over the next 40 years. That's not large historically seen, but for a change to policy, that's pretty huge. And that would increase, obviously, then the population size by roughly 3%. Oops. So this table shows the difference in health insurance premiums compared to current law baseline. The red one is under the premium financing, and then the gray and the black lines are under payroll and deficit financing. So first off, under payroll and deficit financing, we assume that households pay current Medicare Part B and D premiums, and that's roughly $2,000 per person. So those obviously drop from current levels of roughly $6,500 per person. Under the premium financing, you don't see a whole lot of action early on, and that is the result of insuring everybody, and that includes a bunch of really sick people, and a drop in administrative cost going from private to Medicare. Over time, that decreases because cost growth rates in Medicare are a lot lower than under private insurance. Right, so this is the increase in the payroll tax rate that workers would have to pay for under the payroll tax plan. And so roughly 7% increase, and then it has to continue the increase because health costs get more expensive relative to incomes. This has to be captured by the payroll tax to be fully budget neutral for the Medicare budget. Okay. So this is total health spending compared to the current law baseline. We see a big increase like 2% early on, and that comes from covering all the currently uninsured. And that also includes then the people who were previously uninsured and did not pay for healthcare now start paying for healthcare. So it's a large increase. Then you see a dip, and that comes from lower cost growth in Medicare compared to private insurance over time. But then you see it increase again, and that increase ends up being large over the next 40 years, and that is for two reasons. Number one, the number of people who forego healthcare under the baseline is increasing. So under the baseline, more and more people don't get healthcare, so there's also no associated health spending. In the policy, that's not the case anymore. Everybody's insured, and only a small percentage of people don't get healthcare. And then second, the insured population is just larger than under the baseline. So because people are healthier, they live longer, and it's larger. Okay. So these are the results for income tax revenues compared to the current law baseline. As Ken mentioned, in the beginning you see an increase because all of a sudden the income that was previously tax advantaged, because it was for the employer health plan, is now taxable income. So you see an immediate increase in tax revenues. And then the time path, it shows you how the economy evolves over time, basically. Under the premium financing, people work more over time, and the economy is doing better, so income taxes revenue increases. Whereas under the deficit and the payroll tax scenarios, people work generally less, and the economy does less well. And this is very similar to the payroll tax revenues. Here you see that under the payroll tax scenario, payroll taxes go up quite a bit, as expected. So as Ken mentioned before, there are interesting interactions with the Social Security system. And this figure shows how Social Security spending increases over time relative to the current law baseline. And spending goes up for two reasons. First, as Ken mentioned, now you have a lot more taxable income because we are getting rid of the employment-based benefits of health insurance. And then second, because we're going to have a larger population that is going to show up in the later years of this graph. Federal debt. So not unexpected, under the deficit financing, federal debt is going to be a lot higher. One thing to note, though, is that we assume that people pay current Medicare premiums for Part B and Part D, and they make up roughly a third of the total cost of healthcare for somebody who is of working age. So if you would assume that away, that would go up even further. Under the premium financing case, people would work more. They have more money to save because of lower premiums and higher incomes. And we see a big decrease in federal debt. And that is, much of that is coming from the fact that the increase in income taxes is not paid towards financing the Medicare expansion, but it goes into the general budget. Okay. And this figure shows how productive capital in the economy will evolve over the next 40 years. And it's basically a mirror of how federal debt evolves. And this is a crowd-out story. With deficit financing, you have higher deficits. That means that households will save more into government bonds and less into productive capital. Whereas with premium financing, we have lower federal debt over time, and people have saved more into productive capital and thereby increasing capital and output, which is next. So this graph looks very similar for the same reasons. More capital means more output. When workers have more capital to work with, they're more productive, they produce more. That leads to higher wages, and higher wages lead to more hours worked. So in the deficit financing case, it's the opposite. And the payroll tax here is actually interesting. It's going up. It's after 40 years, the decrease in GDP compared to what would have happened under current law is relatively small. Yeah. So I think that's it from me.
All right, thanks, Felix. Mark will talk a little bit, and we'll open up for Q&A and kind of go from there. Thanks, Mark. You want to do it from here? Or?
No, I'll stand up.
Okay.
Although that put me further away from my notes, which I will then have to lift up, but we'll take a chance here.
Right.
So, I'm glad to see not only Kent developing this overall budget model here at Wharton that can be used for so many things, but that he's dipped into healthcare and used that model to do things that other models have not been able to do. There are there's virtually perfect competition, actually, I believe, in this market for simulation models of healthcare spending growth and policy changes. At the Washington Nationals games next year, they're not going to have the presidents running around. They'll have different healthcare budget models running around. The Kent doll, the CBO doll, and so forth. I don't know who gets to be Teddy in terms of the models there, but and I will try to beg your sympathy a little bit. The problem that I have with models is, so here's what will happen. A model will yield a prediction. The most recent ones were actually in connection with Elizabeth Warren's proposal, and what did the Urban Institute model say, and what did the University of Massachusetts model say, and so forth. And then a reporter will ask you, since you're supposed to be an expert, but it's not your model, well, what do you think of that model? They read the executive summary, they have the conclusions, but you don't really know, even as an expert who knows little something about this industry, what's inside the model. So, and the whole essence of these models is that there's lots and lots of moving parts, and it's very hard, even if you read up on the literature that describes them, and people do try to do a good job to describe their model, it's awful hard to visualize what's going on. The best analogy I can think of is it's trying to look into somebody else's sock drawer and see what you find there. I mean, they may know where their socks are and there's other stuff there, but you as an outside observer can't quite figure it out. And I looked in my sock drawer this morning. I've got an expired passport, my great-grandfather's pocket watch, and a silver dollar. So there are various versions of those things are in some of these models. The virtue of the Wharton model is twofold, I think. One, most of the models actually, and I was a consultant on one developed by Douglas Holtz-Eakin, the former CBO director, after he set up his consulting firm, developed mostly by people at the University of Minnesota. The models tend to, with an alarming degree of precision, be correlated with the predictions that whoever the backer of the model is would have liked to have seen the model make. So there's a certain, I won't say partisanship, of course what you get out of a model depends on what you put in the model, but somehow there is that. And I think one virtue of this model is, as exhibited here, I think, the conclusions don't toe any particular party line. They give you a much more nuanced, a much more varied description of what likely outcomes are going to be. The only other one that I know isn't particularly partisan is Rand model, but Rand rhymes with bland, whereas this model's got some moxie, saying some things that you might not otherwise have thought of, and so I think it's valuable for that purpose. And the other reason I think it's valuable is that it goes further than most health simulation models, Some of them do have a tax simulation hook in, but most of them don't go very far for the macroeconomy as a whole. They kind of end with saying, well, here's what will happen to what the government has to pay and maybe what citizens have to pay for health care, but then they don't turn the crank further to say, well, what impact is that going to have on the economy as a whole? And here you have all of those connections put in place. So that is a very great virtue, I think. Now, I will say, since economists are supposed to say something critically helpful or helpfully critical, I have a few comments along those lines. One is, this is kind of what I realized in my experience with the Holtz-Eek and Steve Parenti model. When we would be asked, I was on the advisory board to review the model, well, you couldn't really figure out exactly what was going on, or even approximately, but you could do two things that seemed sometimes to help. One was to say, I see you have this prediction from the model. That sounds crazy to me. So either something's wrong with the model or there's something wrong with me. But either way, explain better what the connection is between what you put in the model and what causes that prediction to come out. So I know we're not supposed to judge, according to Milton Friedman, models by their predictions. Maybe we are, but anyway, that's one approach. And then the other approach is to say, well, I noticed that at least this parameter that goes into the model, you had to pick a number because that's what you have to do, but that number is really, really debatable. It's really squishy. And so let's see what happens. This would be sensitivity analysis if you move that number around. Sometimes it doesn't matter because whatever happened when you increased that number, it got canceled out somewhere in the model, but sometimes it makes a whole lot of difference. And so it's at least helpful to begin by starting with the squishy parameters and then seeing something I'm sure that Kent and Felix are going to do, which is show the sensitivity of results to assumptions about those parameters. So those are my general comments. Oh, the last thing to say is this is Medicare for all, right? That's the headline. But this is not your grandfather's Medicare for all. If your grandfather is Senator Sanders anyway, because, and he could be, because this is today's Medicare, which is actually, I'm fairly terrified. One reason why I continue to teach is my dad lived to be 104, and so when I said to my wife at 65, should I retire? She said, I don't want you around the house for 40 years, so I'm still teaching. But the other reason is that and I'll get to some more detail on this, I feel much more comfortable with Penn's health plan than I would with Medicare's health plan. The current Medicare health plan, which, for example, has no cap on out-of-pocket payment unless you buy a Medicare Advantage plan. But if you buy original Medicare, you could end up being bankrupted by Part B co-payments. It also has deductibles. It has the hole in the donut has pretty well closed. I guess they filled it with jelly, but it's still kind of crazy. And of course, it has the members of Congress as its board of directors, which is probably the most terrifying thing to think about when it comes to your health insurance plan. So this is not that. Well, now let me comment on four things. So one prediction, I guess I have to say, I am a fan of Obamacare. Partly because correlation is not causation, but a group of us, including some of my former colleagues here at Wharton, designed a very similar plan for George Bush the First, which the Democrats declared to be dead on arrival when it was introduced by the Republicans, but then the Democrats 10 years later, 15 years later, 20 years later, I guess it was, introduced the same plan, which barely squeaked through, but it did. And I think it's a good idea to have means-tested benefits for health insurance for people who need it. And I don't want to get too far into the Democratic debates. I spend too much of my time talking back to the television anyway. But it does seem sensible, whether we're talking about college funding or whether we're talking about health care, to put direct subsidies to people who need them and not to the millionaires and billionaires who, I guess Warren Buffett is on Medicare. You guys are paying for Warren Buffett's health insurance. I don't know how that makes you feel. Well, anyway, so the punchline I think here is that this is different The part that, I'll mention four things quickly, and then I think we'll have more interesting general discussion. But one is the prediction about the increase in the percentage uninsured. I'm not too concerned about 2060 personally, but I am concerned about 2035. And as I said, I'm a fan of Obamacare, and I guess I think if it works the way it's supposed to, and it kind of seems to be working that way, it should pretty much stabilize the fraction of the population uninsured. We're right now somewhere between 8 and 9% of the overall population uninsured. The model says 10%, but that may be the number for people under 65, I don't know. But whatever it is, that's been pretty stable once the Obamacare was phased in. It's ticked up a little bit last year, but it's plus or minus 1%. And if you think about it, at least as far as I could tell, there wasn't a whole lot to drive people to uninsurance, even though the individual mandate, which I personally strongly favored, was abolished, because there's a heavy subsidy. So if your income is below 400% of the poverty line, some way or another, you're only going to pay less than 10% of your income toward your health insurance premiums. It seems like that should continue forever, and that should be as a backup for people to continue buying health insurance. Now, for people who get employment-based coverage, it's a little trickier. Actually, one of the great advantages of the model, I think, is that it talks explicitly about how we workers actually pay for our own health insurance. If Medicare for All was passed and Penn no longer had to pay for health insurance for me and Felix and Kent, your tuition would not go down. Our wages are supposed to go up, right? Yeah, well, who's this for anyway? So that would be what economists would say, and most economic models actually say that, but most economists say that under their breath because businessmen don't believe it. Some of them believe, for example, that high business healthcare costs are the tapeworm that's eating the American economy. I don't know who could have said that, maybe you know, but some people have said that somewhere out there in Nebraska. And according to economists, you may be rich, but you're not that smart. It may not be true. But so what's driving that it was my question. What's driving the increase in the percent uninsured? It's excess spending growth, which could be, and I'll come back to this a bit, some assumption about the trend of healthcare spending, but because the person's contribution to the premium, which is what should determine whether they take coverage or not, is fixed by the ACA rules, it's a little, I mean, there's always some evil Knievels of health insurance that just don't see the point of health insurance and don't even take it when they have income 500% of the poverty line and their boss is only charging them $1,000 for a $6,000 premium for plan. But the great majority of people do, and of course with the Medicare population, my demographic, we all take Medicare, even though it's crummy insurance. Why is that? It's because we only pay 10 cents on the dollar, and it may not be that great, but it's sure a bargain, and so we love it. I'm not worried about Medicare for all, I'm worried about Medicare for me, and I hope, we don't have to share our ill-gotten gains with the rest of the population. That seems to be what's in mind here. So I don't understand that, but maybe in the discussion, Kent and Felix or somebody else can explain it. One thing that could be driving it is in the baseline, now not in the Medicare for All scenario, is, as Kent noted, the idea in the baseline is that the administrative cost of insurance will be reduced dramatically by moving to Medicare for All. And 1.1% is the typical number, or not the typical number, actually 2% is the typical number, but is the current number for Medicare administrative costs. That's a little bit bogus, though, for two reasons. One, that's only the part that the government pays as government spending. But about 35% of people on Medicare are in the Medicare Advantage, and that insurance carries up to a 15% administrative cost percentage. So you can sort of do the math in your head. If you turn the crank 35% times 15%, you end up with a Medicare loading in total, summing the loading that the government pays to maintain its records and the Medicare for All plans pay to do what they do, of around 70%, which is still about half, or maybe a little less, a little more than half of what private insurance comes in at, although it's about what large group insurers like our insurance at Penn comes in at. So I don't think it proves that the government insurance is that much more efficient, if that was a debating point. But that could be a reason why people might be forecasted to drop private insurance if that loading, administrative loading, as we call it in the insurance world. We use all these interesting words like loading and moral hazard and so forth. Other than that, insurance is not exciting at all, but at least some of the language is. But the punchline here, I think, or at least as far as I can tell, there seems to be no trend toward higher loading costs in private health insurance. In the last 10 years, what's called the, wrote it down here, but I can't find it, but the administrative cost of private health insurance, or of health insurance in the National Health Expenditure Accounts, has increased at a slower percentage rate than overall national health expenditures. So it's been growing for sure, but not growing all that fast, and not growing actually as fast as the benefits that it pays out. There's a lot more you could say about, is Medicare more efficient or not? The Medicare administrative cost per person insured is about the same as the Medicare administrative cost, as the private sector administrative cost per person insured. But we don't know what's, so that's one of those soft numbers, I think, where, at least from my point of view, it would be interesting to see a simulation if the cost saving was more like down to 7% from 13% rather than down to 1.1% from wherever we are in the private sector now. I think that would all be useful to do. The third thing that I'll mention is, a reason why, I guess I need to say this, and a reason why private sector administrative cost is higher is not because it costs the private sector more to process claims than it costs Medicare. That looks pretty similar, about 1% or so. The real reason is what are called selling and billing costs, and those are primarily arise because you have choice when it comes to private insurance. Actually, the higher costs for those Medicare Advantage plans comes from the fact that you have choice amongst them. But in a sense, and this is why I talked back to Senator Sanders, the reason why it's not an unequivocal gain to have lower administrative costs if everybody's in one plan is you've lost the possibility of choosing one plan or another. And I think it's an empirical question how much Americans really do have different preferences when it comes to their health insurance, although the evidence, I think, suggests there is quite a bit of heterogeneity because, well, look at Penn, we have 4 plans and people are spread across all of them. Not everybody picks the same one. If only we all wanted the same thing, we wouldn't even need democracy, right? We could just appoint one of us randomly selected as a dictator, and that person would do what's best for them, which would be what's best for all of us. But because of heterogeneity, that's why economists like markets, and that would be lost if you go to a single plan for everybody. So, I hate to say one size fits all. Everybody could wear size 44 regular, but for some of us it would be too small and some of us it would be too large. And in fact, what happens in Medicare is people who do take original Medicare send it out for alterations. That's called Medigap, and they buy insurance to kind of top up, or Medicare Advantage, they buy a different insurance than what was collectively chosen back in 1965. So anyway, the punchline here is that there is a cost, and actually the problem is not getting what you want, but getting what some politician chose for you is in economics a cost in terms of welfare, right? Does it show up in GDP? Well, it could if it affected labor supply, but with Medicare for All, I'm not sure that it would affect labor supply. It'd be kind of like, what if everybody was mandated to buy a dozen Chia Pets, right? Now, I don't know what you do with Chia Pets, but it would stimulate the economy, it would provide employment, it would increase GDP, but it wouldn't increase gross national happiness all that much, I don't think. because it's semi-useless, or at least it's not what people really want. So that's the last point on that. Two other small points I'll make quickly. The link to health outcomes. My speech to the American Society of Health Economists was a homily on the subject. We economists need to get together and actually prove that more insurance improves people's health. And we really haven't proven that. The story is natural experiments like expand Medicaid or don't expand Medicaid seem to suggest positive effects on health, but more rigorous designs like randomly assign some people in Oregon to get Medicaid and others to stay where they are doesn't seem to show a substantial improvement in health. I guess having married a doctor's daughter, I'm sort of programmed to believe medicine has something to do with health outcomes, but at the margin, I don't know. And so the parts of the model that are driven by the connection between health insurance coverage and health outcomes seem to me to be a little soft, or at least subject to useful simulation about, well, what if medicine just stops you from itching but doesn't really make you more productive? I mean, that could be kind of the story, or gives you peace of mind but doesn't really help you get up and go to work on Monday morning or whatever it might be. Then the last point I'll make has to do with something that is a task I have. I'm a part of a committee that's trying to work up a statement on the growth of healthcare spending and what to do about it. And one of the articles of faith among most health economists is that the healthcare spending, which actually has tailed off a bit from its long-run rate, is still higher than GDP, but it's driven by beneficial but costly new technology, at least hopefully beneficial, but guaranteed more costly new technology. And I guess you'd like that to be in the model rather than just assume to proceed the future at the rate like it has in the past, except until the Great Recession, at which point somehow it tailed off by 50% of its former excess, but it's still there. You'd kind of like to know what determines that or what might affect it in the future. If we could just defund the NIH, for example, we could get healthcare costs under control in this country. But that wouldn't be my proposal. So I think that's the last thing I wanted to say. There's one more thing, which has to do with the proposals to reduce payments to hospitals and doctors. Okay, so first of all, there's a kind of macro question, so maybe Kent and Felix can say something about this. If all we're doing is having someone do the same job in medicine as they always did, we're just not paying them as much as we used to, which of course is what all the European countries do. They don't pay their doctors or their nurses nearly as well as we do. Is that good or bad for the American economy? Well, they're Americans too. In fact, I see some of them here. So it's obviously better for us as consumers of healthcare to have Senator Sanders cut down on what hospitals and nurses and doctors get paid, but it's not good for them. And what is gained by consumers in terms of additional purchasing power is lost by healthcare providers whose incomes are cut. Now, most doctors I know have had a marginal propensity to consume greater than one. So actually taking income away from them would be a real drag on the economy because they're hyper consumers. But whatever is the story, you'd sort of like to see how that redistribution part works out. The part that's more serious, this is my last sermonette, is that a lot of our healthcare spending is not cost in the economic sense of opportunity cost. It's excess payments to orthopedic surgeons, to nurses with advanced degrees, to the widows and orphans who own drug company stock, except if they bought it at high prices. It's not really, they didn't do anything wrong. But whatever it is, it's not real costs, and I'm not actually sure our real costs are that much higher than the rest of the world. For one thing, we have about the same fraction of our labor force in healthcare as the rest of the world does. And so then I guess the challenge, since I can give all these assignments to Kent and Felix, is, well, does the model predict there will be a massive shift of resources as a function of Medicare for all? And if the resources in healthcare and the resources in the rest of the economy stay about the same, then in some cosmic sense, the economy's no better, no worse off. than it was when we started. So, but let's hope it's better off. Thank you.
That was terrific. Let me actually send, because I'm going to be directing Q&A in just a little bit, and let me respond a little bit to those excellent comments, and then we'll just kind of open it up. And it's definitely true, more complexity in a model, the more black box it is. And so one of the things that we'll be posting is, when they have time to go into a lot of detail, is that we really try to make sure we don't overfit the model, in particular hit certain targets, but then let what economists refer to as the over-identification restrictions kind of do the talking. And in particular, how much does the model, when things aren't tied down, how much does the model actually correctly predict on lots of other variables, in particular, especially heterogeneous incomes and wealth dimensions. So, for example, if you're trying to calibrate to some certain macro variables, are you just naturally out of the model getting other targets? And so we have this deck, we only showed a few pages of it, believe it or not. It has over 100 pages, and we talk about lots of those other targets. And that's not always, proof that the model is doing a good job, but at least opens up the model a little bit more if you're not willing to dive into code and look at it that way. And I completely agree on sensitivity analysis, which we plan to do much more of. These simulations take quite a while to run, and Mark was joking with me, was the ink dry, because we were still writing some of these as of yesterday. And so let's talk about a couple of things that Mark brought up. The first one is our prediction on the uninsured rate. And depending on what source that you look at, it's the data is roughly around 10, 11%. And we, in fact, are naturally getting the other, this is an example of where the other figure is how many people are not getting actual medical care. That is, they're not even paying out of pocket. That just naturally comes out of the model, and it happens to nail the data very, very well. And so then what happens in this framework, this is where a lot of the complexities, and I agree, we have to really unpack it and explain the story well, is because of because of excess cost growth over time, in the private plans, who drops out first? People who drop out first, even on employer-based plans, which are group plans, the people who drop out first tend to be healthier types. And so that, in fact, increases the required premiums over time. This is the classic adverse selection problem. And so then, even though a lot of these people are being heavily subsidized on employer-based plans, they actually choose to drop out, even though they're on an employer-based plan. And it's not that they're just, non-working. We don't have a third of the population or 25% of the population not working. They actually just will in fact, drop out, even though they're heavily subsidized. So there's an adverse selection problem that's dynamically happening in the economy, which, again, we really do need to explain in a lot more detail. It's definitely true that there's this big debate on how competitive are labor markets. If you were to, in fact, get rid of this benefit, would wages really increase? First of all, would they increase quickly, and would they, in fact, increase all the way to fully absorb? And if you look at the data, the best studies on this is actually outside the United States. It does look like, at least in the long run, wages would probably increase most of the way there. But even if they did not increase all the way, one of our points here is that the financing mechanism really does matter a lot, and that's going to kind of be first differenced out by a lot of this stuff. The Medicare Advantage point, 35% and the overhead cost there is exactly right. So we didn't have time to talk about it. There's the excess cost growth, and then there's the overhead rates. And in particular, in the private plans, we're assuming a medical loss ratio of about 85%, about 15% overhead right now. In the Medicare system as it is today, we take a weighted combination of fee-for-service Medicare and Medicare Advantage. And so our cost, our overhead rate there is not the 1-2%. It's currently at 9%. Sanders' plan, they claim that they will try to get it down to 2% by getting rid of Medicare Advantage. I completely agree that just to take that at face value is challenging. One of the issues, in fact, with Medicare, where it makes the comparison with private pay a little bit misleading, is that private pay spends a lot of money on the selling. They also spend some money on dealing with, looking through the claims, and these are legitimate charge. Medicare has a little bit more of a spotty history on that, hence the fraud in Medicare. And so some people claim a lot of the fraud detection is not included in the Medicare loss ratio, that's just kind of fraud that happens that really should be deducted from the medical loss ratio. And in terms of the welfare, we have not, and this is an incredibly important point that Mark has brought up, GDP is not a good summary statistic for welfare. In particular, in fact, I can't say why I got tenure here at the Wharton School, but a couple of papers that probably contributed to it was really making this point. In particular, one of my papers showed that, privatizing Social Security or going to a flat tax system, you could grow the economy while actually reducing welfare. And the reason why is that going to full insurance, yes, it could actually contract the economy like under the payroll tax financing, because the payroll tax financing it creates some distortions. There's this disconnect between what I pay and what I get, so therefore I'm going to distort my labor supply. I could still be better off because that insurance is actually getting rid of those really bad states of the world where I am uninsured and I have a heart attack. And so the value of insurance reduction is actually incredibly important. In fact, better insurance actually means that people can save less precautiously, and less precautious saving means less capital. It can actually reduce the capital stock by actually improving insurance. But that doesn't mean that people are worse off just because GDP is lower. So economists have been trying to say this. We will release welfare results on this, and we're going through those right now. There's a couple of cautions that Mark brought up that we're going to have to really qualify, especially when we release analysis of Sanders' plan and so forth. It's stuff that we're not handling. For example, we're taking health innovation that continue. We see tremendous health innovation in the United States. We're taking that as exogenous in this model. It's not we really have lots of interactions going on. But in fact, discoveries, cures, therapies, all those incredible large, small molecule discoveries, all that stuff we're saying continues to chug along. Mark's point is you might want to think of what economists call the endogenous growth framework, where in fact those things actually become endogenous in terms of how much money is available in the healthcare system. Totally agree with that. And that is something that will be on the plan. I mean, that's a tough model. So endogenous growth models outside of healthcare were all the rage about 20 years ago, and then they kind of went away because then there's lots of evidence kind of against them. But as economists, we have to believe endogenous growth. Yes, the mad scientists facing a 99% marginal tax rate may still do these discoveries, but we really do think that people do respond to incentives. Thomas Edison wasn't just motivated by great intuition and science. In fact, there was a profit motive there as well. It's been hard to detect in the data, but nonetheless, we're definitely going to have. Now, those are differenced out in kind of what we're doing, but not completely. There will be some differences as well. I think the last point is what keeps me up at night that Mark brought up. And that is when you think about compensation to like physicians, hospitals, and so forth. Those who advocate for Medicare for all will often just view that as pure rent. We're just overpaying doctors because doctors have figured out how to create barriers to entry, and therefore there's no marginal effects. As somebody told me, is that if doctor compensation went way down, hey, there's still waiting lines to get into med school, so everything's going to be grand. It's all just kind of rents. And so forth. There's been articles that actually say that's not true. In particular, they look at different skills. Maybe this really high-performing surgeons didn't have to become doctors. They could have gone to Wall Street. In fact, one of the puzzles, one of these papers that published some years ago asked is why do doctors actually make so little? Because, they may make, a top surgeon may make several $1 million a year. Probably a smart dude or person, and they could have gone to Wall Street and made even more money. So what we call the Roy model of occupational choice is something that you'd love to get in here. That is down the road. But that is a big debate. Is it rents, or is this, if it's rents, it's not a problem. You just reduce how much you're paying in rents. It's always a good thing. You should always figure out how to tax rents. Or, in fact, will these actually have big effects in terms of people and innovations, in terms of who actually, the types of people are going to med school? It's not just that, yes, we may still be able to have lots of people going to med school, but are those the people that you want to do open heart surgery on you someday, or do you want that person who otherwise went to Wall Street and is doing something else with their life? And so these are tough questions. We don't have great data on that. International experience gives us some clues here, but it's not perfect. There's a lot of reasons why Europe is not a great model for understanding the U.S. system, especially lots of innovations that happen here and percolate elsewhere. But those are going to be open questions. It's why we have a whole department in healthcare, and it's because these are questions that are going to be ongoing for a long time. All right, that's my shtick. Why don't I open up for questions, and we'll just kind of take it. And please wait for a microphone, because we are. Oh, by the way, this is being recorded, just in case that's of concern for you. In D.C., we have to say that to staffers who are often concerned about that issue. And just please identify yourself really quickly and who you're directing the question to.
This is for the panel. My name is Tara Khan. I'm a nurse practitioner and a PhD student at Penn. I think for progressives and a lot more Democrats than before, the idea of Medicare for all is sort of what is important. The actual proposals, how we get there, is sort of less, but the idea. If we have a President Sanders or a President Warren, and it looks like we're going to need to move, or they're asking for help to move toward a workable bill, I think all of us that saw, the outcomes, increased life expectancy by 1.8, almost 2 years, uninsured down under 1%. It is great. Of course, the bittersweet part of it is we see the cost as you have projected to really go up. If you were being consulted on this plan, President Sanders, President Warren, brings you down to Washington, D.C. to work on a workable Medicare for all plan with the idea of a universal single-payer system, what changes would you recommend? And also, I'm wondering, when you're running your model for this, are you considering running, for example, at the one saying that Medicare Advantage is taken out, so you run it at 1% to 2%? Will you run these other possible scenarios to see how it could actually work?
Yeah, let me answer the second one first, since it's not normative, and that is right now when we create Medicare for all, Medicare Advantage and everything else about Medicare is sticking around. So that hasn't changed, and one of the points about the Sanders plan is to get rid of Medicare Advantage to try to take advantage of the lower cost growth rates. So at Penn Wharton Budget Model, we do analysis. We try to avoid recommendations. I can talk about efficiency, and that's kind of my workaround. But actually, I'd like to hear Mark's point. More on the healthcare side. I'll talk about financing in just a second. I'd love to hear Mark's insight. It sounds like you played a big role in kind of a lot of changes. You said you're a big fan of Affordable Care Act. But there might be changes that you still want to make.
Well, certainly there are fix-ups to the Affordable Care Act that I think, I would prefer I guess what we would need is a Sanders or Warren victory and Democrats to establish a filibuster-proof majority in the Senate. Is that good? If that would happen, maybe it's time for me to retire. I don't know. But I think the fix-up to Obamacare, well, there's really basically, I think it's a mandate that has teeth in it. More than half of the uninsured are actually eligible for subsidies, either eligible for Medicaid, but they haven't gotten around to signing up for it, or eligible for enormous subsidies at their place of work, but they just decide not to take insurance. So a mandate that said you have to do that, and the mandate we proposed actually had as a penalty the premium for the net premium for the lowest cost insurance plan, which at your income level you would be eligible for. We might as well be insured because you're going to pay for it anyway. So if we want to cover 100%, well, that's never true, but 99% of the population, that seems quite easy. The other part, which is much harder, is to make health care and that health insurance affordable, but well, I don't think anybody can prove that it's not affordable under the Affordable Care Act. 10%, less than 10% of your income if you've got a high income, and a smaller percentage of your income as the income goes down. It's a value judgment, of course, but that's that. I think for purposes of imagining that suppose we do have a Sanders or Warren type Medicare for all, I think Kent's model kind of shows you the trade-offs. You can have a premium model, I think that's what it was called, which is a fixed dollar payment that people are supposed to make independent of their income for public purposes. And in public finance, I learned that was called a head tax, which usually then we turn up our noses at because it's not equitable. Everybody pays the same thing, at least above some income level. But that's what's in Warren's proposal to finance the plan by requiring that the current employer contribution, which for want of a better assumption, we assume falls equally on all workers, is just transferred to the government. If that's okay with you, it's okay with me, and that is the least economically distortive. And then, as usual, if you want to do something that seems fairer by having the rich pay more than the poor, or the upper middle class pay more than the lower middle class, I think, as usual, Senator Sanders is the most honest about this. For those of us who are lucky enough to make a decent income, our income taxes will approximately double to pay for it. But then you can decide, of course, in your heart of hearts, whether it's really worth that goal to you or not. But if the rest of your fellow citizens go for it, that's what you're in for.
Yeah. Hey, let me say just two things, because I'm not going to advocate for a plan, but relative to what Mark just said, if you look, so the Affordable Care Act clearly did not have a strong mandate. I said in 2012, I was interviewed on TV about this, I said it would fail because the mandate was too weak. Where I grew up, rural Ohio, below poverty line, you have to bring a 2x4, to get people to agree to things. A little, $95 the first year penalty, that ain't doing it. And by the way, only levied on positive tax refunds, another nuance, by the way. But if you compare Affordable Care Act with Massachusetts, remember Romney Care? Massachusetts actually had very high kind of compliance and so forth. In Massachusetts, the penalty was set at essentially the half of the lowest, which is
it still is.
It still is, yeah. And so what happened there is that you actually, if you would basically pay half of the premium. The lowest premium is about the average premium. Basically, pay half of the premium, walk away with nothing. And so, and also when it comes to adverse selection, what we call this relative tax, it actually deals with adverse selection because one of the issues with ACA is that the penalty was independent of premiums, whereas in Massachusetts it was tied directly to premiums. So if you have adverse selection, what happens? Premiums go up, but your penalty goes up as well. You have this automatic feedback loop that tries to deal with adverse selection that you don't have in the ACA. So we know that the way that penalties are constructed, there's a constitutional issue about mandates versus taxes, but we know that the way penalties are constructed are super important. The second thing is, I'll just come back to the financing issue, is that, yes, it's a head tax, but we also do, if you can't afford the head tax, it's like with AstraZeneca commercials. If you can't afford your prescription, AstraZeneca can help. And we call that Medicaid. So the Medicaid sticks around and basically says, and as well as SNAP and so forth, for really low-income people, they'll actually pay either part or all of the Medicare premium. Of course, in that case, you give up something. You got that disconnection now between payment and benefits. In fact, to qualify for Medicaid, given that it's asset tests on the non-housing assets, people will often drive down assets. We see that in the model as well to qualify, and that creates more distortion as well. So there's always trade-offs. Yes.
Hi, I'm Shalama Freed. I'm a postdoc at LDI. And I hate to drive home this endogenous versus exogenous growth when it comes to medical technologies, though I am always happy to be on the right side of an argument from Mark Pauly.
Yeah.
I was thinking more in the context of life expectancy and whether the life expectancy calculation, which it sounds like it's not, is included in, or if advances in medical technology is included in that life expectancy. So I'm thinking about this in the context of, let me take you all the way back 30 years to Burton Weisbrod talking about the healthcare quadrilemma and talking about how basically the insurance companies and the medical device and innovation industries basically feed off each other. And so if we now have this situation where it's like a monopsony, as opposed to, being able to kind of, pick off of multiple different insurance companies, now you're just picking off the government itself. Does that slow down innovation? And if it does slow down innovation, then what happens to life expectancy in terms of, your competing illnesses, as in, we took care of heart failure, and so now we're going to go take care of whatever the next, competing illness is going to be for the person that's like the oldest. So I guess that's one.
That's in the question.
Yeah.
That's a great question.
So I think about it in terms of life expectancy, but then I'm also thinking about it in terms of financing. And on the flip side of it, if it doesn't stop medical technology, then what will happen in terms of like our spending? Is essentially just going to explode, because now every single thing that comes out on the market ends up getting funded, like how, ends up getting, included in a formulary, included in whatever your health insurance plan is.
Yeah, no, those are both good questions. Let me point out this 2 years increase in life expectancy. That's relative to life expectancy under current law. So even under the current baseline or current law, we're projecting life expectancy will continue to increase. Although, as we know, there's certain dips the last few years. But nonetheless, it would. So this is an additional 2 years as a result of this. But you're coming back to a good question. That honestly, the data is really, really challenging, and that's just endogenous kind of growth stuff. And that is, we don't have that in the sense that we believe that medical innovation is going to continue. But if you actually thought, because these aren't rents that the excess cost growth aren't representing, or physician payments and hospital payments, these aren't rents. These are actually pools of capital to support innovation. Then that would mean that some of the projections here are optimistic in terms of Medicare, the advantages of Medicare for all. Now, a lot of the differences that, in terms of funding mechanisms, those will mostly be differenced out. But nonetheless, if you're actually trying to analyze a specific policy, you want to take a stand on that. So what some people will say, they'll look at other countries and they'll say, well, wait a minute, what's the big deal? Their doctors get paid a lot less, and it looks like innovation continues and so forth. That's misleading. And the reason why it's misleading, in fact, Darren Acemoglu, not focused on healthcare, but in innovation in general, has pointed out in a JPE paper a couple of years ago, is that you can have a lot of heterogeneity in the sense that you have some countries that are real innovators, and other countries he calls kind of the warm and fuzzies that are not the innovators, but they benefit from this spillover effects from the innovators. This efficient frontier continues to expand even for them, even though they will continue to grow and so forth. And the point is that we all can't be Scandinavia, was his point. And that is, you will actually have this natural equilibrium where some focus on innovation and some focus on more redistribution. And so it's misleading, therefore, just to look at other countries and just take it as given, especially when you have a handful of countries that are really pushing the innovation frontier, and it creates spillovers for other countries. All those things are really important, and I think we'll continue to kind of look at that. It's really hard to extract that out from the data, because if you just did a simple crosstab across countries, the argument would be, no, innovations, it just it continues along. It doesn't really seem the Europeans are adopting innovation like the United States, but that doesn't say where the innovation is actually initially generated. Yeah. Other questions? Yeah.
Hi, I'm Dominic. I'm an econ student, and I wanted to ask 2 questions. They're both small. About the budget model on the slide with the growth in GDP, is this compared to the predicted growth in GDP under the current law?
Yeah, it's relative.
So relative to what you project GDP to grow to by 2060? Or
That's right. It's everything's relative to what the variable otherwise would have been. So we definitely are saying GDP under baseline would have grown. This is the delta relative to that.
And so the mechanism for that would be just by increase in health and productivity?
Oh, you mean in the premium finance case?
In the premium finance case, yeah.
So there's a couple things. One is, yes, that a lot of it's driven by a couple factors. One is people in general becoming more healthy. We also have more people. And so GDP is a sum of all those things. But also because we're spending less overhead costs in the model. And this comes back kind of the Mark's point. If what do we think about doctors who are getting a lower reimbursement rate? How much savers or consumers are they? But nonetheless, what that does is that cost saving efficiency it allows households to also save more money, and that eventually builds up kind of the capital stock.
Gotcha, thank you. And I wanted to ask Professor Pauly how we make a mandate with teeth, since not close to 100% of Americans are filing income taxes, and that was where we previously had the penalty levied. So I just wondered where we would put it.
Oh, well, so, I mean, not filing income tax if you have high income is, I guess, another kind of fraud. So it's easy for Kent and me with tenure to say somebody ought to do something about that, but somebody ought to do something about that. Otherwise, the main, the healthcare costs in the U.S. are not high because of poor people. They're high because of well-off people. So it wouldn't be... I think it wouldn't be that challenging to enforce a mandate on the people who need a mandate. For low-income people, at least what I envision, what's true in Obamacare is you make it free or virtually free or heavily subsidized. They still need a push, right? All those people who are eligible for Medicaid, but well, I sympathize with them, just don't want to take a day down at the welfare office or wherever to sign up for it and be mistreated and so forth. We could certainly market those programs a lot better, but some states are actually not so eager to market their Medicaid programs. But you could certainly pick up those people, I think, fairly easily with a combination of carrots and sticks. And then for the Evel Knievels of healthcare costs who make 400% of the poverty line and above, and there's about 4% of them who run around uninsured. They probably don't wear jackets in the winter either, but and what's wrong with them? But I think a penalty that says you're going to pay for your health insurance, almost 100% of it anyway, why not have health insurance would do the trick. Now, the political backlash is much harder. I mean, I don't understand. I'm very much a free market libertarian sort of person, but I don't understand why people should have a right to run around without health insurance. Like, as I said, running around in the winter in your underwear or something like that. You have a right to do it, but it's bad for you and unlovely to the rest of us. And so
I've known you for a lot of years. I did not ever hear libertarian come out of your mouth.
Oh, okay. Well, at least in terms of people being able to do whatever they darn well please.
I see,
That's what I mean.
Okay. Let me leave you with one flag. I'll get you out at 5:50 as promised. So about half the population files income taxes because they actually have a tax liability. Another 20-some% is because they get the EITC and other things that you can only get through the tax form. So you have this big gap of non-filers. So one of the things in Massachusetts, they'll send you a bill. I mean, they'll come after you if you, in fact, do not comply. And so the question I had for some of the designers, they say, why don't you just take the Massachusetts approach? And, the official answer was, there's maybe some constitutional issues. There's also some issues where how do you do things like an average premium tax across different states? Is that constitutional for the government to have different taxes across states if it's tied to actual premiums in those states? And of course, that's a bogus response because the government already does that. Premiums vary across states and so forth. I think a lot of this was, on the Affordable Care Act, is that Congress just felt really uncomfortable sending out bills, and a lot of that was a challenge. It's also the reason why they actually would not levy the ACA fine except unless you actually not only file taxes, but you had a positive tax refund. And so because they didn't want you to kind of have to pay taxes unexpected, they kind of wanted to kind of sneak it out. And that becomes, of course, where I grew up, you bring the 2x4. You have to go big or go home, is what I said on this. All right, so that's a wrap. Thanks so much for coming. I really appreciate it.